liberates nitric oxide. وكلنا متذكرين شو mechanism of action of nitric oxide. هلا why is it used for the treatment of hypertension? Because it mainly works on the arteriolar side, so less effects on venous vascular smooth muscles. When do we use them? Can we use these drugs in emergency? This drug has a very fast onset of action, but as soon as we stop the infusion with SMP, it's usually given by an IV infusion, we will lose the effect. Some of the side effects يصير عندنا rebound, hypertension, and tolerance develop for this drug. حكينا عن الديازوكسايد اللي عتاعنا اتهجى فيها. We said it's very similar to minoxidil in its mechanism of action. It activates potassium channels, mainly also in the arteriolar smooth muscle cells. Doesn't have a lot of effect on venous smooth muscle cells, resulting in decrease in the total peripheral resistance. The difference between هذا الدواء main difference with SMP, this drug duration of action is longer, so it stays between 6 to 24 hours. Another important difference, if you remember about SMP, an overdose of it would be dangerous and still be accumulation of toxic metabolite which contains cyanide, so it can cause lactic acidosis. We talked about labetalol and carvedilol.
Yes. Yes.
So remember again, these mechanism of action, it's different. You know, in addition to being beta blocker, they are also alpha-1 antagonists. So we would not worry about reflex tachycardia, and we do not need to add a beta blocker for patients taking this kind of vasodilator. So what do we do when I have a hypertensive patient? This hierarchy represents in different cases. We start usually with thiazides. Thiazides are prescribed in patients who have mild to moderate hypertension. And with regard to what number is it, احنا متذكرين حكينا by definition hypertension is above 140 over 120. Although the American guideline has changed recently in 2008, we have new guidelines where we have above 130 is considered stage 1 hypertension, below 130 is considered a high normal, and it is normal but high. فله مصطلح pre-hypertensive. And then stage 2 is above 140 or 150, and above 180 is considered a hypertensive crisis. But either whichever guideline we follow, لساتهم بالجامعة الأردنية يتبعوا above 140. This is where we start to give medication. But let's say I have a patient who is 130. He either pre-hypertensive, according to the previous classification, or stage 1. You would start, first of all, with lifestyle modification. So you tell the patient to lose weight, to restrict his salt intake, to exercise more.
Stop smoking.
Stop smoking, excellent. So we want to do these non-pharmacological modalities of trying to lower hypertension. And we follow up with the patient. After 1 month, of course, we don't just rely on the clinic measurement. We give him a table, a book, and we ask him to read his blood pressure every day, 2 times a day. If he comes later, he still have hypertension, we start with treatment. What kind of treatment we start with? We need diuretic. Diuretics, it's preferable in which kind of people?
Black and old.
Old patient and blacks or African American. لاحظوا حتى إنهم African American, they respond very well to diuretics instead of other stronger antihypertensive medication. So according also to the ethnic background of the patient and the age of the patient, we determine what is the treatment. So thiazide is one example of a diuretic. It's least expensive, very effective first-line therapy for mild to moderate hypertension. Other uses, we can use it for volume overload associated with congestive heart failure. If I have a younger patient, instead of a diuretic, I can start with the ACE inhibitor or ARB, especially for moderate hypertension. Then we decide what kind of diseases does my patient have. Does he have increased risk of diabetes? We would try to avoid drugs that causes insulin insensitivity or glucose disturbances such as beta blockers. So if I have a low risk for diabetes, we go with beta blocker as the second treatment. If it's high, we go with the ACE inhibitors. حكينا. What about ARBs? If the patient cannot tolerate the ACE inhibitor, we switch him to angiotensin receptor blocker. If this does not provide adequate control, we will add another medication, either calcium channel blocker. إذا المريض حطينا على beta blocker, we can add an ACE inhibitor. If still the patient is not having control over his blood pressure, then we revert to one of the ones regulating the sympathetic nervous system. So alpha blockers, for example, or one of the sympathoplegic agents. So
دكتورة
according to that.
يعني الكالسيوم شانل بلوكر ما استخدمه وحده، يكون additional drug.
إذا كان عندي low renal hypertension, calcium channel blocker works very well, better than beta blockers for those kind of patients. فبيعتمد على age of the patient and kind of hypertension. So this diagram here shows us comparison between high renal and low renal hypertension. So with low renal hypertension, patients respond very well to diuretic or calcium channel blocker. With high renal hypertension, we do beta blockers or ACE inhibitors. If this is not sufficient, we have to add another drug. So we either add an ACE inhibitor or a beta blocker. يعني إذا بلشت بACE بضيف البيتا blocker. إذا بلشت ببيتا blocker بضيف الACE inhibitor. وزي ما قلت لكم الACE inhibitor it's a substitute or a substitute for it is R. عشان هيك مش موجود الR عندي هون. If nothing works, we add either an alpha blocker or spironolactone. Spironolactone is an aldosterone antagonist, it's a diuretic. Or as we said, if we have refractory hypertension, we go towards the sympathoplegic agent. في هذا الالgorithm, it's not very clear. Can you read it? So this is the American Heart Association guidelines to treat hypertension. Again, they have the same information that we mentioned, but you can also rely on this one. So it's according to the age. Here, different, what's the blood pressure value? Does the patient have diabetes? Does the patient have chronic kidney disease? Is the patient black or a non-black? So for blacks, for example, we initiate with thiazides or calcium channel blockers alone or in combination. If that doesn't work, we said we're going to add another treatment for those kind of patients. I can send you a copy of a more clear picture of this if you are interested, but what we want to rely on, I don't want to complicate it too much with multiple diseases, is what we learned in the classes and the diagram I put here in this previous slide. But it's actually the same thing. في هنا عندي شو lifestyle modification we can do, and there's another page of it that's giving me certain restrictions in different kind of population.
هسه هم مين بيعمل أكثر جلوكوز intolerance؟ البيتا بلوكرز ولا الأس انهبيتور؟
البيتا بلوكرز.
البيتا بلوكرز بيعملوا أكثر جلوكوز. طب ليه؟
ليه؟ لأنه إحنا نعرف إنه في عندي البيتا adrenergic receptor موجودين بالليفر. So it's going to affect the metabolism. It's going to affect glycogen lysis, glyconeogenesis. Yes, so that's why it's going to affect. وبيأثر برضه على insulin sensitivity as well. So what kind of future consideration? هلا first two parts we have some studies that showed us that calcium channel blockers and ACE inhibitor combination is better than beta blocker thiazide in reducing cardiovascular events. Other papers have showed that multi-drug approach to manage hypertension. What drugs are these? Statins, beta blockers, diuretic and ACE inhibitor, aspirin and folic acid. So different people or different groups are conducting different clinical studies to look at the best approach. What is our purpose of lowering the blood pressure is to prevent cardiovascular incidents or attacks. What do we call it? Cardiovascular events.
Complications.
A new technology that was in clinical trial, I was trying to look up if it's in the market. It's implantable mechanical baroreceptor to control high blood pressure. So in conclusion, what are the most common antihypertensive drugs that are used nowadays in the market? They range from diuretics, ACE inhibitors, or of course ARBs. Don't forget about ARBs. كثير هلا صاروا يستعملوا ARBs instead of ACE inhibitor because they became cheap, as cheap as comparable. Calcium channel blockers and beta blockers. With relative few side effects, low cost, these agents provide effective blood pressure control. And the combination strategies are useful in managing hypertension and also preventing long-term cardiovascular events from occurring. The special population, I put this slide to just summarize what is suitable for each of these special populations. It's just a summary of what we talked about in the previous lecture. So, in pregnancy, again, if a patient is taking a drug before pregnancy, most antihypertensive medication can be, she can stay on her antihypertensive medication. Which ones are these? If she is on a beta blocker, yes. If she is in a calcium channel blocker, yes. But if she is in an ACE inhibitor or an ARB, no, we have to switch her for something else. So, except for ACE inhibitors and angiotensin receptor blocker. Methyl-dopa is the most widely used drug, especially when hypertension develops. يعني مريضة ما كان عندها hypertension and she develops hypertension while she was pregnant, we will prescribe methyl-dopa because, as I said, some studies have indicated that there might be some drawbacks or side effects to the fetus from the use of beta blockers. وشو البيتا بلوكر اللي حكينا يفضل هو لابيتيلول. For African Americans, diuretics have demonstrated to decrease morbidity and mortality and should be the first choice. Also, calcium channel blockers and alpha beta blocker can be effective. Usually patients do not respond very well to monotherapy with beta blockers or ACE inhibitors. You have to add a diuretic in African Americans. In elderly patients, it's very important to remember to start with low doses and then increase the dose gradually to see the effect on those population. ليه؟ لأنه sensitivity can become more decreased and the window of safety of the drug decreases with age. So we try with a low dose and see how it works for that patient. Of course, we have to keep close monitoring of side effects. For example, drugs that were centrally ممكن يؤدوا ل cognitive loss أو disabilities. We have to watch out for hypotension, postural hypertension with alpha-1 blockers, especially هدول المرضى إذا لا سمح الله وقع وانكسر he needs to be hospitalized. It's going to be very يعني hard thing for him. هلا for diabetes mellitus we use either ACE inhibitors, alpha antagonists, calcium antagonists are effective. With regards to diuretics, at a low dose, they are also tolerable. We wouldn't worry about causing glucose intolerance. Patients who have hyperlipidemia or high LDL levels, also diuretics at a low dose have little effect on cholesterol and triglycerides. One study has shown that alpha blockers decrease LDL-HDL ratio. So this is something advantageous because we want to have a higher HDL and a lower LDL level. What other drugs can be used? Calcium channel blockers, ACE inhibitors, angiotensin receptor blockers do not have side effects on changes in the lipid profile. Patients who have obstructive airway disease, we should avoid beta blockers, especially the non-selective beta blockers. هاي السلايد هي ضلت معكم من محاضرات الدنتستري, but it's يعني I focus a little bit more on the oral side effects with dentistry. فممكن تهمنا as well. Most of the antihypertensive medication cause dry mouth, as you can see here. Other special side effects related to the oral cavity, beta blockers, they can cause taste changes. برضو حكينا كثير مهم ACE inhibitors حكينا captopril for example, it causes taste changes. We talked about calcium channel blocker causing gingival enlargement زي nifedipine والamlodipine. Okay, direct acting with dilated facial flushing, increased risk of gingival bleeding. كلمة lichenoid reaction is it's an immune reaction where we have hyperkeratinization inside the oral cavity. بصير عندي هيك زي منطقة فيها hyperkeratinization بتكون represented as white flaky area. It can be autoimmune, but it can also be drug-induced. So this is with regards to talk about antihypertensive medication. A very big topic, but we try to simplify it as much as we can. Remember all the special characteristics about the drug and how to use them.
دكتورة
Yes.
الجنجيفال هايبربليجيا هي سايد افكت للدايهيدروبيريدينز اونلي لو نون دايهيدروبيريدينز also دايهيدروبيريدينز النيفيدبين
الأول
نيفيدبين والنون
للنيفيدبين وأخواته
ودي ال تي ازام واخوانه
لا ما بيعمل اللي هم دايهيدروبيريدينز للدايهيدروبيريدينز. We have some introductory slides. I'm not going to cover them thoroughly. I know you've learned about atherosclerosis in pathology. So what is atherosclerosis? As you remember, it's a form of arteriosclerosis where in addition to having this sclerosis of the blood vessel, we have a deposition of a material. That's why the name came شاني athero from the Greek word paste أو gruel. يعني نوع من أنواع المعجون شيء هيك لبن ملزق بالأوعية الدموية. And sclerosis meaning stiffening or hardening. So we have a disposition of an atheromatous plaque containing cholesterol and lipids on the innermost layer of arteries. So what will this lead to? لما يصير في عندي هذا build up of cholesterol, it's going to cause narrowing of the artery. In addition, these inflammatory mediators are going to cause structural changes in the structure of the blood vessel, leading to less elasticity of these blood vessel, more passive effect of them, leading to what we call sclerosis or hardening of these blood vessels. So بيبطلوا compliant and they become more stiff. I'm not going to go through this. You've learned it in pathology. But I like this picture. You've probably seen something like it. This is a coronary artery, and you can see what is a big change when we have this atheroma that's inside the lumen of this artery, how much narrowing we can get to this coronary artery. Now, what is the leading cause of death worldwide?
heart diseases.
Heart disease or cardiovascular diseases. And most importantly, coronary artery diseases. What leads to coronary artery disease? There are a lot of predisposing factors that can increase our risk of coronary heart disease. From these factors are other pathologies, such as hypertension. If we look at this diagram here, it's showing us the fold increase of a number of cases of coronary heart diseases in relation to different conditions. So hypertension increases the chance of getting coronary heart disease by 2.3 degree. What about high glucose? High glucose increases at 1.5, smoking increases at 1.4, and left ventricular hypertrophy increases at 1.5. What about this? Cholesterol is the highest number we see, it's 4.5. So this factor alone can cause 4.5 increase of your chances of getting coronary artery disease, which can be fatal. And the good thing about it, some of the risk factor for development of atherosclerosis here, it's led by high glucose level, can be controlled. So we have modifiable risk factor and we have non-modifiable risk factor. Some of the non-modifiable risk factor we cannot change in whole age. So usually it progresses when you get older. Gender, men are more prone to develop it than women. but after the age of 50 or 60, incidence become more equal. Family history, so certain genetic diseases. What kind of genetic diseases?
diabetes mellitus and diabetes mellitus.
وغيرها.
LDL مشكلة بال LDL
Yes,
metabolism.
excellent. So problems بالreceptor, for example, of LDL. So we have mutation, genetic mutation that lead dysfunction of the metabolism of lipids. And then we have the modifiable risk factors, such as hyperlipidemia, hypertension, cigarette smoking, diabetes mellitus. How do we modify these? By taking proper treatment. So I take treatment to lower my cholesterol level. I take treatment to lower my blood pressure. We stop smoking. We treat our high glucose or treatment of diabetes mellitus. Other factors, for example, disorders of coagulation or homeostasis and thrombosis. Certain infections, such as herpes and chlamydia pneumonia infection, can increase your risk of developing atherosclerosis. And finally, sedentary lifestyle or obesity. So we need to exercise more, we need to lose weight. All of these things we can change in order to decrease our risk of developing atherosclerosis. For the non-modifiable, اللي هو genetic predisposition, maybe in the future we will have genetic treatment, اللي هو insertion of the correct gene or correction of the mutation, and these can be modifiable as well. So, what is the genetic example of genetic predisposition for atherosclerosis? We have familial hypercholesterolemia deficiency or mutation of LDL receptor. بدي ركز شوي على LDL receptor لأنه one of the drugs that work to treat high cholesterol levels, they're going to affect the LDL receptor. We'll talk about that in a minute. Hi, this slide is just showing us what's the normal numbers. So it's above 160, that's considered high for LDL cholesterol. الأوبتيمال يكون أقل من 130 من 130 ل 160 يعني it's normal أو borderline. Yeah, slides I'm skipping on pathology, we're not going to ask you about them. So we said we have different kind of drugs to treat hyperlipidemia. First thing we want to try to modulate the diet. If not, we will go through these drugs. So we have statins, we have fibrates, we have bile acid sequestrant. And let's start talking about statins. مين متذكر كيف يشتغل الستاتين أو مين مر عليه بحياته هذا الدواء؟
الكوليسترول سينثيز دكتورة انزيم MG.
So we probably learned about it in biochemistry, right? So it inhibits a central step of the cholesterol synthesis pathway, هذا الباثوي الطويل الموجود هون اللي هي HMG-CoA reductase. So it is a rate limiting step in the synthesis of cholesterol. So how will this affect our LDL level? احنا بنعرف انه في two sources of cholesterol we have in our body. One is the endogenous source that comes from synthesis of cholesterol, and then we have the animal sources. If we have too much cholesterol, it's going to stay circulating in the body. When I inhibit the synthesis of cholesterol, so I'll have less amount of cholesterol in the liver. So the liver needs to maintain the same amount it had before. So it upregulates the number of LDL receptor on the surface of the liver. So they uptake the circulating cholesterol. This lowers, or this results in less amount of serum cholesterol. So which is our aim of treatment. So example of these drugs, you have simvastatin, atorvastatin, pravastatin. Usually these drugs range in their efficacy. They cause a decrease in LDL by 30 to 50%. They work through inhibition of HMG-CoA reductase. As I said, these drugs are reductase inhibitors. This reductase usually catalyzes the conversion of HMG-CoA to mevalonic acid. مهمة شوي هاي الجملة، أنا مو حطلب منكم كل الباثواي بس بدي إياكم تعرفوا mevalonic acid. We want to know another part of the pathway that we will go to in a minute. So they block the synthesis of cholesterol. هاي اختصار الكوليسترول، اختصار غريب بس this is how I put it. In the liver, decreasing hepatic synthesis, which will lower total and LDL. This will lead, حكينا, to increase in the clearance of LDL through increase or upregulation of the number of LDL receptors. So these drugs have positive effects on morbidity and mortality with relatively few side effects. One major, one common side effect associated with them اللي هو myopathy. يعني بيسببوا ألم بالعضلات. A lot of patients complain about this. The effect هذا especially increased if you give a combination with another lipid-lowering drug that causes this side effect as well. We have example of these. We have nicotinic acid derivatives or fibrates. That's why we want to make sure that if we combine these two drugs together, we want to make sure that the lysis of the muscles, we have to keep monitoring the levels of the enzyme that indicate we have a damage that happened to the muscles. ممكن يصير عندي شيء اسمه rhabdomyolysis in the case of combination. But for statins alone, يصير عندنا myopathy and tolerance develops to this side effect. One way to get over this is we start with a low dose ونبلش نزيدها للمريض gradually so we wouldn't have to worry too much about that side effect. Next, I'm just putting this table. So either one of them. The purpose of this table is showing us that these different kinds of statins, they differ in their efficacy. نلاحظ إنه أقوى two statins هم atorvastatin and rosuvastatin. At a high dose, they can give us more than 50% decrease in LDL capacity. At lower doses, بيعطوني من 30 to 50%. Compared to simvastatin. Simvastatin is the father of this family, of the protype. And it's actually a prodrug that needs to be activated in the body. And then we have the low intensity one, اللي هم low doses of pravastatin and lovastatin and fluvastatin. مو مطلوب منكم تحفظوهم, just know the group as general. هلا for the practical part لما تروحوا على المستشفى أكثر أشياء تستعمل عندنا هم هدول الدوايين. These are the structures of them, بس برضو as I told you, we don't have to memorize that. Hello, why are statins so famous? Statins have promising pharmacodynamic actions or protective actions to the cardiovascular system in addition to other parts of the body. What are these actions? They improve endothelial function. شو مقصود endothelial function? شو الانdothelial وظيفته بش اسمها؟
يتحكم بالvasoconstriction dilation.
Excellent. يتحكم بالvasoconstriction dilation. So it's going to secrete things that cause vasodilation and things that cause vasoconstriction. When I talk about endothelial dysfunction, usually I relate to it not being able to dilate. And this is related to which substance released from the endothelium? NO. Excellent. So when I talk about endothelial function, mainly I'm focusing on NO. So by endothelial function, I mean improvement of the ability of endothelial cells to secrete nitric oxide and thus cause vasodilation. Other effects it have, it can reduce vascular inflammation, platelet aggregation, it has antithrombotic effect, it causes stabilization of atherosclerotic plaques. هذا كلها من وظائف الستاتنز أو من الأشياء اللي اكتشفناها إنه ممكن الستاتنز تساعد فيها. It can cause increased neovascularization of the ischemic tissue, it causes enhanced fibrolysis, immune suppression, and also osteoclast apoptosis while increasing the synthetic activity of osteoblasts. Hello, how are these drugs? Yes.
ايش بنستفيد من neurovascularization of the
بالهارت الكولاترال circulation اللي بيtalk about it يعني بتزيد blood flow to areas where we have less blood flow and يصير في new blood vessel formation to perfuse ischemic areas.
ال HMG CoA هو الريت limiting state.
Okay. Now, how does this happen? Part of these pathways or pharmacodynamic effects of statins can be explained by this pathway as well. Again, mevalonic acid gets converted through multiple steps to something called gurnal pyrophosphate. Gurnal pyrophosphate gets converted to something called gurnal pyrophosphate. And this is associated with prenylation of proteins. Prenylation is a post-translational modification that does something to proteins. What does prenylation cause? It's a signal for proteins to translocate to the plasma membrane where they get activated. So example of this protein is a small protein called PRAS. Yes, excellent. So these are G proteins actually. Another one that's of more interest here in the cardiovascular system is called the RhoA. So the RhoA, the small protein, once it gets prenylated, it gets activated, it goes to the plasma membrane, thus leading to multiple effects through its activation. شباب معلش بحكي أحد يتكلم هنا. اوكي. شو الشيء اللي بيعمله؟ متذكرين الروكاينيز اللي حكيت عنه بحدث الاسكيميك هارت ديزيز؟
حكيت عن دواء بيعمل انهبيشن.
تمام حكيت عن دواء بيعملوا انهبيشن، فهو it's associated with contraction in vascular smooth muscle cells. الRho-A is an upstream modulator يعني هو بيعمل تحفيز للروكاينيز، الروكاينيز بيعمل activation للcontraction. الRho-A برضه والروكاينيز pathway has been associated with limiting nitric oxide levels in a lot of pathologies. فبالتالي some of the good effects of statins is through inhibition of formation of gurnal pyrophosphate, inhibiting the activation of those small G proteins, زي Rho-A, which will prevent the activation of rho-kinase, thus preventing vascular smooth muscle contraction, increasing nitric oxide release, and a lot of other effects. So with regards to their pharmacokinetics, احنا مش كتير بنركز عليها. They are well absorbed orally. They are extracted in the liver. One important thing about these drugs, they are inhibitors of cytochrome P450, and they actually differ in their ability to inhibit the enzyme. But there's a lot of drug-drug interaction with these drugs. Also, they are substrates of cytochrome P450. عشان هيك you would worry also about drug interaction with these agents. أغلب substrates are inhibitors. ليه؟ لأنهم they're going to bind to the drug, so they have a recognition site to the, they're going to bind to the enzyme. So they have a recognition site in that enzyme. So what are the clinical uses of statins? They can be used to prevent myocardial infarction and stroke in patients who have atherosclerotic disease following an acute myocardial infarction, or as a primary prevention in patients who are at high risk of having these myocardial infarction or ischemic heart disease, because we have found out that their cholesterol levels are high. And either after the cardiovascular incident occur, we start giving them drug, or before we wait for that, if we do a lipid profile for that patient and we found out that he has high LDL level, then we're going to start statins. Actually recently, guidelines from the American Diabetic Association, they started to advise to prescribe statins for diabetic patients above the age of 50 because of their protective effect on the cardiovascular system, these other effects we talked about, other than the cholesterol lowering effect. And usually we call that those effects pleiotropic effect. يعني what kind of pleiotropic effect in general, الآثار متعددة إلهم. They cause improvement of endothelial function, and by definition endothelial function means increase in the release of nitric oxide as a vasodilator. They cause upregulation of eNOS. They have anti-inflammatory effect. They reduce the odds of plaque rupture. In addition to that, they cause inhibition of the NAPDH oxidase-mediated isoprostane formation. This helps in prevention of platelet aggregation. They modulate phospholipase A-mediated thromboxane formation, also important in antiplatelet effect. And as I said again, they upregulate endothelial nitric oxide synthesis. Now the adverse effects, we can have mild gastrointestinal disturbances. They affect liver enzymes, so we have plasma, increased activity of certain liver enzyme, and most importantly, they can cause severe myositis or rhabdomyolysis if they are combined with other lipid-lowering drugs that also have that side effect. So we're going to stop here, and